Hi, Mathieu.
Hi.
Hello. It's a pleasure to see you both. We enjoyed your presentations because subarachnoid hemorrhage is a very tough issue, and there is still a lot of controversies about subarachnoid hemorrhage. So I thank you, and I have some questions about your talks. We can start with the monitoring indications. All the recent work in the management of the DCI are based on invasive monitoring, especially those of the PICO system of the transpulmonary thermodilution. And I wonder if you can to every subarachnoid hemorrhage patient, even the ones with good neurologic status, or those with a low radiologic status. I mean, a small hematoma in the brain. So, which will be the indication? What patient should have the invasive transpulmonary thermodilution catheter?
That's a very good question. Of course, there's no good investigations on that, except for the Annensberger trial, which I showed, which is done actually in all the adults as AC patients. Of course, it was a small trial, so it was not possible to do sub-analysis of, for instance, patients with a better neurological status on admission. So, but I cannot exclude that even in good patients that PICO might be good in the end. But of course, it has all kinds of practical problems, because in our hospital, the good patients will not always be at the ICU. They will be on a nursing ward sometimes, not always at the critical care unit. And then it's impossible to do the hemodynamic monitoring. So we call it the high care, the neuro high care in our hospital. So there's increased monitoring, but they don't do invasive hemodynamic monitoring. So that's the first thing. It may have, it depends on the organization in your hospital. And the second is, I think that, of course, in the patients who have a good neurological status, I think the best monitor in those patients is actually the neurological status. So when a patient is neurologically 100% intact, then I would not suggest to do hemodynamic monitoring. So I would especially suggest to do that in the higher risk patient, and especially the patients who have an ICU indication because of decreased consciousness or blood pressure problems or neurogenic pulmonary edema. So I think it's all about risk estimate. If the patient is at high risk, I think you should think about why not to do the hemodynamic monitoring instead of why to do it.
Thank you. Dr. Oliveira, you published some years ago a classification of vasograde scale. Do you think that vasograde classification will help us to define the level of monitoring the patient?
So the initial idea of the vasograde came from this perspective. So when we developed the hospital policy, the hospital protocol for the management of subarachnoid hemorrhage patients, we were trying to actually divide them in different levels of risk. And that's how we came out with the vasograde. But as Mathieu was saying, there's nothing actually published out there. We would have to test, right? We would have to test what would be the best monitoring strategies according to different grades. You could use anything, but you could use vasograde, you could use WFNS. Anyways, the thing that has not been tested. And the other thing that I think it's important to mention is that non-type of monitoring tool, zero, has been proven to change outcome in any given disease. So if you use something to detect a specific disease and you don't do the right treatment, it doesn't actually mean anything, right? So what I want to say that, for example, we keep the patients in the ICU with continuous EKG and continuous saturation monitoring, and there's no evidence that this changed outcome, right? Especially because the number of changes that you detect are not that high. So you would need to include such a high number of patients in a study to show that there's compelling evidence to use any type of monitoring. So that's why I think maybe we won't find this type of studies. I don't think we're gonna do this type of studies. But we could actually study other stuff, right? As Mathieu was saying, in their hospital, they keep patients with a low grade in the regular ward or in a high dependence unit. In Canada, they don't have step-down units in most of the places. They would keep these patients in the ICU for 15 days. So.
Okay, thank you. I wonder if the measurement of the cardiac output with a truly non-invasive device like bioimpedance or bioreactance devices could help us in this situation. I don't know if there is. I searched and I didn't find any specific work in this pathology. But do you think you both think they can help?
Yeah, I think they can surely help, because I think the added value in suprarenal hemorrhage of such a device, of course, we don't have the studies proving that, but I think it's a device that may help to see that when the pulse pressure is good and the cardiac output is good with a non-invasive device, that can help you to see that the patient, for instance, doesn't need fluids. So you should stop giving fluids and still be confident that the cardiac output is still good enough and not decreasing, for instance. So I think these types of monitors can especially help to show you that cardiac output is good. And it means when cardiac output is good, then your preload, your venous backflow to the heart is adequate, because otherwise you cannot have a good cardiac output. So I think it can help to titrate down your fluids and give less fluids to the patients and prevent fluid overload. So I think there's a lot. I think we should do studies with these devices. I think that's a very good idea.
Okay, and going to the invasive monitoring, Dr. Muto from Japan, which you both talk about, proposed the transpulmonary tremolution with a GDI index of 800 milliliters per square meter. That's not normal. That's a bit higher than normal. So my interpretation of Dr. Muto's work is that he's in fact proposing a very slight hypervolemic management of the patient. Do you agree with this interpretation?
Well, I think the other study, I hear what you're saying, but first of all, in spite of the high GDI, they still gave less fluids to the patients that had the PICO. So that means, in my view, that the patients that did not have the PICO were even more fluid overloaded, because the PICO patients were already hypervolemic with the PICO device, and still the outcome was still better because they got less fluids. And in the Annetzberger trial, I think the cutoff was to keep the GDI above 640. So this is a little bit lower. So they had a more normal value, and still they found a benefit for DCI. So I think this monitor, so whether it be the PICO or the non-invasive devices, bioreactance or impedance, I think when you have a monitor that shows you that you can stop giving fluids, that could be beneficial to the patient. And it can, I think the other talk with the autoregulation, I think that should be the next step. We should, do blood pressure management. Blood pressure management with autoregulation might be a good way to go, I think. And fluid management, we should do it in the high-risk patients with some kind of monitor. And it can be invasive or non-invasive, I think.
Okay, thank you. And another question about albumin. Albumin has been proposed since many decades ago, and now it is not used very often. There are some units in the world that use albumin, and some other units, most of them do not use albumin. I will ask both of you, what do you think about albumin in this context?
I think there's two different strategies to use albumin. One as a fluid, a colloid fluid replacement. The problem that the albumin is very expensive. So that's why most of the places they don't usually do. And there's the albumin as a modulator, the study that Jose was trying to run. He did a phase 2 trial, but the phase 3, I don't know what happened. I think didn't have grant to run the study as an immunomodulator or decrease the inflammation anyways. So the idea probably as a fluid replacement, you would require less fluid unless you use you have to use higher albumin concentration. In the SAFE study, if you see the TBI subgroup analysis that had worse outcome, but they use a very low albumin concentration. So you were giving albumin with water. So you would have to use higher albumin concentration and as a colloid. But as I was saying, still there is no evidence, and albumin is expensive. And as a neurological medicine, we still need some data. And Jose has this study. I don't know what happened that he couldn't analyze the study. He could not conduct the phase 3 trial.
And maybe to add to that, I think it's very interesting to do a randomized study with a higher concentration of albumin. So that should be the 20%, I guess, not the 5% that was used in the TBI studies, because it's hypoosmotic. But what's very important if you want to study albumin in a randomized clinical trial, because there's now not enough evidence to use it, in my view, is to standardize all other treatments. So I personally do not believe in one silver bullet like albumin or endothelin antagonists or whatever. You should mind all the different factors, which I also showed in my presentation. Circulation and all the different variables should be standardized when you want to study one single aspect of management, like fluids, like albumin. So when we would study that, we should standardize all the other treatments, and especially hemodynamic management, because when you don't standardize that, then I think it's very difficult to do a randomized clinical trial and prove that it's beneficial. It's like It's like flying an airplane when you only know how to drive the wheel and don't know all the other buttons, then you will go down for sure. So you have to play all the buttons at the same time and not just albumin or just drug or so I think that should be kept in mind when studying it. We don't use it for the same reason that Leo said. So it's very expensive and there's no clinical evidence to, that's the reason why we don't use it and why we don't give it to the patients. But I know other countries, for instance, Belgium, over there, albumin is free. So I think they use it because it's no cost aspect. So that's what I can say about albumin.
Okay, thank you. Thank you very much. I have a last question here. Is about the hypertension goal. You said that if the patient is hypertensive, you should decrease the pressure, but we don't have to go below the 90 millimeters of mercury bar. But what if the patient is not hypertensive? What if the patient has spontaneously 75 or 78 millimeters of mercury? Do we have to increase the pressure up to 90?
Yeah, well, in my institution, in our protocol, we say that all patients have to have a mean arterial pressure of 80 or higher, just not to get too low. And in the talk of Lucia Rivera, she found that a lot of patients needed, I couldn't understand everything because my Spanish is not so good, but so most of the SAH patients had the lower border for the autoregulation of a MAP of 90 millimeters mercury, 90. So 80 may even be too low for the sicker patients. So the guidelines I referred to was in the patients with an aneurysm that was not yet occluded. And we saw in the Himalaya trial is that actually some patients were so, they had such a high level of sympathetic stress, at least that's what we think, that norepinephrine did very little. So we gave very high doses of norepinephrine, like maybe 0.5 or 0.6 micrograms per kilogram per minute, which is really high, which is actually kind of dangerous, I think. And not much happened to the blood pressure. So that's also an issue we should think about. The patients that have already a high blood pressure have a high sympathetic drive, and then norepinephrine doesn't add so much. So I think especially the patients who have a relatively low blood pressure, yeah, I think it's wise to give them a little bit higher blood pressure, especially in the acute phase, like first week or something. But we simply don't have the answer to all these detailed questions. But I think when blood pressure is still low, it's reasonable to increase the blood pressure, especially when the patient gets worse neurologically.
But if the patient if the patient is asymptomatic, do you still increase the pressure?
We tend to aim for a mean arterial pressure of 80 or higher in the acute phase.
Okay.
Yeah, but we do not do this outside the ICU, but because the doctors don't give norepinephrine outside of the ICU. So it also depends on the logistic reasons and the organization of the hospital.
Okay, I see a further question. Javier asked if you use the Doppler, Transgenium Doppler to set up a goal of blood pressure. Do you use Transgenium Doppler for a goal in blood pressure?
In the Netherlands, we don't. But I also have to say we did an analysis of the SAHIT data. So that's the international trial data with that is done by Locke MacDonald in Canada. he's not anymore in Canada now, but and we saw that in the centers, especially in the United States, compared to Europe, that outcome of subarachnoid hemorrhage patients seem to be a little bit better in the United States, where they do much more neuromonitoring. And in the Netherlands, we tend to be a little bit, we are not so aggressive with monitoring and therapies that do not have a strong evidence. But I'm not sure if that's right, because we do a lot of things. We don't do a lot of things. And in America, they do a lot of things which don't always have the evidence. But it seems that maybe outcome in America might be a little bit better. So I'm not sure that doing not so much is always good for the patient. I'm sorry, that was not your question. Oh yeah, the Transgenium Doppler. No, we don't use it. So that's the same story. It's not evidence-based, so we don't use it. But I'm not sure that it can. Of course, I think it can help to make a risk stratification of which patient is at higher risk, and that might, of course, be of clinical value. So
no, I think what Jorge was trying to ask, if we can set up a blood pressure target, a blood pressure goal using the transcranial Doppler, and it's something that is not easy, like to find the ideal blood pressure, right? That would be a dream, right?
Yeah.
Like the PRX, if we could use the transcranial Doppler as the PRX to actually find the range that the patient would be better.
I've been trying to set up research with laser Doppler, and that's kind of a laser Doppler and nurses and NIRS combination strategy. It's called Diffuse correlation spectroscopy. And with that, you can actually measure cerebral blood flow through the skull at the cortex of the brain. And when you have that signal, it's not yet ready for bedside use, but when you can measure the cortical blood flow through the skull, and you can relate it to blood pressure, then you would have the ideal measure of autoregulation. And then you can use that to titrate your blood pressure. That would be ideal, but I think autoregulation guided blood pressure management, we should try to make that the next step for the SAH patient. But it's difficult because no one has really done that trial yet. I think Licia Rivera should do that trial.
Certainly. I have a question from the audience. Is to Mathieu. Any data about back keeping mean arterial pressure more than 80 millimeters of mercury? I don't understand very well the question.
No, it's not. It's actually based on the fact that that we feel that below 80 the patients have more risk, but there are no strong data about that. This is just a local protocol, and it's not very evidence-based, I have to admit.
Okay, thank you. And the last question is about someone who asked if you know any evidence of posterior reversible encephalopathy as iatrogenia in this setting.
That's an interesting question. I don't know it, but I think I know why this person is asking it, because in the posterior circulation, there are more, if I say correctly, there are more receptors that respond to less receptors that respond to norepinephrine with vasoconstriction. So that's part of the pathophysiology of posterior locoencephalopathy, is that the vasoconstriction of the posterior circulation is less strong than the anterior circulation, and that's why you get this hyperemia and edema in the posterior circulation. For some reason, we don't see that a lot in subarachnoid hemorrhage, even when we give a lot of norepinephrine. So it's interesting why we don't see it a lot, but because we give a lot of norepinephrine. So I think it's an interesting question to do for the research. What's going on there? I've never seen it in 22 years of practice.
Okay, thank you.
Me neither.
Okay, I really very thankful for you, both of you, and Lucia, despite she couldn't join us for the questions. And I appreciate very much your effort to speak to us. Thank you. We have no more questions.
Thank you for the invitation, and I was very glad to be here and to contribute to your nice congress.
Thank you very much.
Thank you, Jorge.
Thank you, both of you.
Thank you.
Bye.
Bye-bye.
Bye-bye.